Heard of Boston Children? I'm sure people have heard of Boston Children, but just to let you know, Central Pennsylvania Clinic is where I like to spend more time, is an Amish and Mennonite clinic in Big Valley of Pennsylvania. And we do a lot of genetic and metabolic studies there. Right out in the middle of the cornfields, and was raised as a barn raising by the Amish. So I'm going to talk about some metabolic studies that I've done, and I have to say at the beginning, I've only tested or studied 7 children with CHAMP1, which is not much to draw conclusions from, but I think there are some things that can be said. So I'm going to talk first about amino acids and mitochondrial function, because that's the best access to what's going on in mitochondria. And then I'm going to show quickly how we analyze the amino acids, then give examples of how that analysis works in 2 other syndromes, then look at what we did in CHAMP1, and then ask the question, well, why should there be mitochondrial dysfunction in CHAMP1, which is not what anyone would expect. So I don't have to say much more about the mitochondria after Dr. Bowles, but just to show that the citric acid cycle, which is where the real work of the mitochondria is, that is in making energy, making ATP, that's also in the mitochondria, that's in the matrix, as opposed to the cristae here where the ATP is made, but the breakdown of food substances to feed into ATP synthesis is done here in the matrix. And the matrix contains this, which is the citric acid cycle, and it has many different inputs to it, but it starts with citrate, as it is called, and then it goes through these breakdown steps. And the reason the reason I emphasize the citric acid cycle and the value of looking at amino acids as a window on mitochondrial function is that essentially all amino acids feed into the citric acid cycle. So amino acids, which are normally used for protein, for making new protein, also contribute to energy metabolism. Here's a set of 6 that feed in there, another set of 4 that feed in there, and so on, tyrosine, aspartate, and asparagine. There are 20 protein-derived amino acids, and they all are metabolized to the citric acid cycle, and the citric acid cycle is what regulates their levels in blood. So having a good way to analyze the amino acids in blood gives you a window on mitochondrial function. So this is how we routinely ask the question, does this condition is it caused by an abnormality in mitochondrial function? So here's a typical plasma amino acid study, and there's a fairly wide range. There's glutamine. The average is, this is one child, the average is 500, and it has a wide range. Alanine is the same. So all the amino acids have a relatively wide range, and it's not easy to interpret these unless you, in effect, you can look at the ranges. But what's more important is not the absolute level of an amino acid, but the ratio of one amino acid to another. So I developed a method, which I won't bore you with, where I normalize amino acid levels. That is, I calculate the ratio of an amino acid to all the others. And that allows me to express the amino acid level as a simple number, average of 1.0. And flagged here in yellow are the abnormal levels. And there are 3 mitochondrial syndromes here, and each has a distinctive pattern. That's the point, that one can learn a great deal about the mitochondrial function and dysfunction in this case by looking at these relative levels. And it's just not as easy looking at an amino acid profile by itself. So one of the syndromes, or one of the conditions in which it was evident, I should say, I ran the metabolic laboratory at Hopkins for most of the time I was there. So I had noticed patients with autism tended to have high levels of alanine and glycine in particular. And there are 2 types of autism, I should say. There are children who are really abnormal from birth, and those who lose their skills after a year or so. And by looking at their amino acids, one can distinguish between the regressive autism, the children who lose skills after a year of age, and those who are always abnormal or have abnormal development. And this pattern, glycine, alanine, or alanine and glycine, and the two things combined is even more significantly high. Asparagine, proline, glycine, and alanine, that's mitochondrial. So in effect, essentially all regressive autism has a mitochondrial basis. Knowing that pattern, as I said, each pattern, each abnormal amino acid pattern tells us what's wrong with the mitochondria, and it gives us a general idea. And that allowed us to put together a treatment protocol based on what appears to be a functional complex 1 deficiency. Complex 1 is one of the complexes in the electron transport chain where ATP is made. And this just shows that with treatment, the children get better very quickly if they have mitochondrial autism. This just shows biochemically. Treatment started in October 2010, and a year later, these increased levels of citric acid cycle intermediates, these are all what were on that big wheel, they've come down to normal. Just the isocitrate hangs up, but it was down 6 months later. So not only is there clinical improvement, but there's biochemical normalization as a result of the treatment. Compared to most classical mitochondrial diseases, this is mild, but it's important to identify it early and treat it, because then the children can get better and some can become normal. So in treating, I treated a child with autism, quote unquote, who several years later, or I advised a colleague how to treat it, and she did very well. And several years later, she was discovered to have a new syndrome, CAT6A. And next thing I knew, my email box was filling up with requests from parents to say, I want the same thing for my child. But I really didn't know whether that was exceptional in that one child or not. So CAT6A, just to describe it, it's a classical malformation syndrome with cognitive delays. There are features obviously that overlap with CHAMP1, but it's interesting with regard to the vomiting that I hear about now, that they do have, the most striking functional problem they have is intestinal dysmotility, gastrointestinal dysmotility. So I summarized the results after the first 28 children I had evaluated. And I found this pattern of amino acids, not as striking as autism, but there's an increase in alanine, which is seen in mitochondrial problems, asparagine as well, and citrulline, which is not typical. In some mitochondrial disease, in fact, the citrulline is low. But so this is really a distinctive pattern, but it did, because citrulline is made in mitochondria or derives from a product from mitochondria. It suggested there was something mitochondrial going on. And the what was particularly, so I did some additional metabolic studies, and one characteristic of mitochondrial disease, of a subgroup of mitochondrial disease, is having low citrate levels. So I measured citrate in the children, and sure enough, it was low in almost every single child. The few children who didn't have the lowest citrate level, it was at the lower limit of normal. What's important about citrate, in addition to its function in the cycle here, it's also the source of, it's the source of acetylcholine, and acetylcholine is what makes the gut move. This makes the smooth muscle of the gut contract. And acetylcholine must be made from citrate that is exported from the mitochondria into the cytoplasm. So if in mitochondrial diseases, often the mitochondria don't make enough citrate. So acetylcholine is low. You can't get acetyl-CoA in the blood, in the cytoplasm. Acetylcholine is low, and the gut shuts down or there's dysmotility. So there it is. So this is just an example of the treatment. We give citrate. That's all I have to do. It's the same thing that's in lemon juice. And this, you can read it. Last year, my daughter started having issues with urinary tract infections, then GI issues, and they escalated fast after COVID. She's now been switched to try citrates, and I think the pain has gone from 100% to maybe 10 or 20% or even less. No muscle relaxants or pain meds were helping. She's back to school, but she loves and happy again. So far, it's incredible. If we were not part of this group, the CAT6A group, our lives would be very different now. This is not an exceptional, this email was sent to me. This was on Facebook. This is not exceptional. It's really a night and day change. And the effect of citrate for the intestinal dysmotility, the cramping that they have, they have multiple exploratory laparotomies for suspected appendicitis. And it turns out to be simply a deficiency of acetylcholine, which can be corrected by giving what the mitochondria aren't making enough of. So I then looked at CHAMP1. There are 7 patients I had looking at the amino acids. And I couldn't ignore the fact that there really is, there's not very striking, but if you compare it to autism, but again, if you look at CAT6A, which is quite variable, some of the children had normal levels of asparagine and some had normal levels of citrulline, but at least half had increased levels. So it's the same proportion here. And the main difference is methionine is high rather than low in those children. So it looked like there might be something going on at the same point that I was looking at the early children CAT6A. So those 2 amino acids were increased. So I measured a few other things. I think I had six studies, and there are 2 abnormalities. One, vitamin E was low. This is about half of the lower limit of normal. In other children, it's quite normal. The homocysteine level is on the lower, this is low, or at the very lower limit of normal. And homocysteine is a marker for a phenomenon that we see in other mitochondrial diseases, which is a deficiency of methionine, not in the blood, but in tissues. And there are a number of problems that can result from that. And by giving extra methionine, those problems can be treated. So I don't know if that obtains in CHAMP1, but it is a suspicious finding that needs to be followed up by more testing. So the question that I come up with then is, if CHAMP1 is a nuclear protein, how could its deficiency cause mitochondrial dysfunction? And that bothered me at first, but then since I didn't know the CHAMP1 literature, I looked at it. And I found an interesting, what struck me was that, well, first of all, I knew ahead of time that mitochondria move throughout the cell to where they are needed, or for recycling damaged or old mitochondria. They move along an actin railroad, what is shown here. And actin is used in many different ways throughout the cell, including in the nucleus for cell division. And CHAMP1 interacts directly with actin. So if one looks at CHAMP1 staining in cells, in a normal cell, you see CHAMP1 which stains green, is co-staining with DNA here. But here it is in the interphase, it can be dispersed throughout the cell. But for the mutations here, the CHAMP1 is throughout the cytoplasm. And what is, I didn't get the slide in. What is important about that, or what why that makes sense is because all mutations that I can see for CHAMP1 is the DNA binding motif has been lost. So the CHAMP1 will not bind to DNA and won't be held within the nucleus, so it can become dispersed throughout the cytoplasm. There, I hypothesize it interacts with actin, and that then interferes with mitochondrial function. And there are many, many diseases where of mitochondrial dysfunction where the primary problem is something in actin or other parts of the cytoskeleton. So there are actually many malformation syndromes which have long been thought to be untreatable. Obviously, you can't undo the malformations, but they still have ongoing medical problems. This is a brief list of some of the syndromes I have treated. And as in CAT6A and CAT6B, there can be some pretty striking changes once you do the metabolic testing and figure out what needs to be done. Here is KIF1 is a part of actin. So KIF1 is a protein that is part of actin. And this is a child, and this child had a KIF1 deficiency and mitochondrial dysfunction. And I started treatment here, and she would have ended up with a very small head, right about there. But you can see she just grew straight up, and her brain grew so fast that she had, it tried to go down her spinal cord. She had to have cervical decompression done. And here's another microcephaly with mitochondrial dysfunction, where again, the treatment wasn't such a huge increase in brain size, but it also caused an increase. So it does work. And these are syndromes, both of these are syndromes which are considered untreatable. Here's another histone syndrome like CAT6A, which is a methylation defect. And long before I knew what his defect was, I identified a deficiency, that he had a secondary deficiency of methionine. And this is the before and after of starting him on methionine. You can see it was pretty much life-changing. So the questions that are left, is there other evidence for mitochondrial dysfunction? Are the citrate levels low? I don't have a single citrate level from CHAMP1, and that's the most essential thing, is to see whether that is low, because it would have an immediate treatment relevance. One of the things that is possible is that the CHAMP1 proteins aren't bound to DNA. It could be that they are overproduced and causing a lot of trouble in the cytoplasm. And there might be ways to downregulate the synthesis of mutant CHAMP1 rather than trying to increase their production, which is often a strategy that is used in treating genetic syndromes. And
Dr. Kelley,
I won't go into the details, but the
can you guys hear me?
endocrine abnormalities that I see in other syndromes are directly related to the mitochondrial dysfunction. I won't bore you with the metabolic connection why that is the case. So that's basically it. What should we do more, or can we look more at children with CHAMP1? Okay.
Can you guys hear me? Jen, Dr. Kelley,
Yes.
Are you able to hear me?
We're able to hear you.
Okay. Just really quickly, because we're so behind on time here. And I thank you so much for your patience in recruitment of this process. I know several people from the CAT6A community who can't say enough amazing things about you and sort of how life-changing the simple supplement was for their community. How many families are needed to get maybe a more accurate picture? I know it's been kind of a struggle to get you the results of the blood work. Would you say 5, 10 families needed? I mean, the primary objective was to get some recruitment for you today.
If we can get 5 more, and especially get the citric acid levels, I strongly suspect that this is there is mitochondrial dysfunction of the type seen in CAT6A because of the amino acid overlap. So the most important thing is to get citric acid levels. And if you had all the 7 I've tested so far, get that done, and another 5 to help with amino acids, I would think with 5, I could make some hypotheses about treatment.
I could promise you that we're going to make another big push for this. Thank you so much for your time. And I will absolutely put you in touch with some families who are interested in and have any questions. Thank you so much for presenting. Have a great rest of the day. Thank you, Jen, for everything today. Appreciate you as well.